have that out. I know the first 3 or 4 or 5 questions here are based off true, false questions. Black lung, pulmonary fibrosis, both these are true, false. We just reviewed black lung. It can cause pulmonary fibrosis. I mean, it's inhalation of dust particles into the lungs. The lungs create scar tissue over it to capture it. I'm not exactly sure how I've worded the question on there, but pulmonary fibrosis would be a restrictive disorder if it comes down to that, because there's going to be some permanent lung damage. As I know we talked about restrictive in there, obstructive was asthma. Myoglobin, hemoglobin. It's probably going to be something. Myoglobin has a greater affinity for oxygen than does hemoglobin. True or false? That is true. Myoglobin is found in heart and in skeletal muscle, and it loves oxygen more than does hemoglobin. So it'll be something like that. Oxygen loading. Well, I like oxygen unloading better because that's what makes us efficient. Loading is right the opposite. There's 3 things that make oxygen unloading effective. It makes us more efficient. Our venous return of blood is 7 to 9% oxygen saturated. That's venous return. We've used the rest, but that's still quite a bit. So there's 3 things that help us unload oxygen. Acid pH, or pH, down pH. Increased temp. And number 3, an increase of 2,3 dpg.
So you want to know about oxygen unloading?
Yeah, this says loading. If you know unloading, loading's right the opposite. Loading would be an increased pH, decreased temp, decreased 2,3 dpg. Let me explain what these are. Let's put us in a scenario here. Put us in a situation here. We have, let's say we're exercising. Where's body temperature going to go as you exercise, up or down?
Up.
It'll go up. An increased temp causes the blood to give off more oxygen. We need more oxygen. What are we going to produce during our breathing process more we exercise? What do we breathe out? CO2. We're going to produce CO2. An increase of CO2 will cause a decrease in pH. Direct correlation here. 2,3-DPG is an enzyme produced by the body due to deoxyhemoglobin, which means lack of oxygen on the hemoglobin. Lack of oxygen on the hemoglobin, the less is there, more of this will be produced if we have the demand for it. If you go move to Denver, Colorado, that's one of the first things the body will do is produce that, because air is so thin, lack of air pressure, your blood's not going to be saturated with it. So you got to be more efficient with the little bit you have. And over time, it'll build blood volume because it needs more carrying capacity for what little oxygen that's up there. So that should help answer oxygen loading. Oxygen loading is the exact opposite of unloading. We're more concerned about unloading. We need to become more efficient with what we're doing. Hypertension, edema. Edema could cause hypertension, obviously. Another true, false. Give me a way you could treat edema or hypertension. Name a drug. A generalized drug that's been used forever. Water pill, diuretic. It's another name for it. Lasix is another one. Yeah. So this is a true-false question, and it's going to have something to do with diuretics, with hypertension and edema. Okay. Brush border, another true-false. Brush border is another name for microvilli in the small intestine. And I'm sure the question is going to be related to that somehow. It's another name for microvilli in the small intestine. It's purpose is increased surface area, and the brush border actually produces some converting enzymes that converts pancreatic enzymes when they get there, makes them active.
Increases surface area.
It's increased surface area, gives us way more absorption. Pathogenic bacteria. That'd be any bacteria that causes a disease or illness. If it's pathogenic, that term's bad. Another true false. Lipoproteins, cholesterol. I'm going to assume it's going to be some kind of a question that's going to ask if LDL's good or bad or ugly, VLDL, good, bad, or ugly, or HDL. Now, LDL and VLDL, they're both bad. HDL is the good cholesterol. Now, lipoproteins are not cholesterols. If it says that, I don't think it will. But ascending limb of the nephron. What's its specialty? Descending, coming down, is water. Ascending, coming up, is salt.
So you just wanna know salt on it, or?
It's going to be salt. It's another true false, but let's just say if it says the ascending limb of the loop of Henle, ascending limb of the nephron reabsorbs water, that is a false statement. Ascending reabsorbs salt, the descending reabsorbs water. Okay? Boyle's law and Charles' law, just give me definitions. They're there in the book. Just grab that quick definition of what it's saying. Respiratory distress syndrome, RDS. Typically, it's in premature babies. If they make it to 34 weeks or past, they have a 90% chance they won't even get it. As the book says, these babies lack sufficient surfactant. I love the way the book says that. So lacking sufficient surfactant, their type 2 alveoli cells have not matured. That's what makes the surfactant. What matures those? Corticosteroids. So if they're 30 weeks along or 32 weeks along, we're going to stall as long as we can, give mom some steroids, hope we develop those lungs a little faster, so when they get here, we reduce chances of lungs collapsing when we get here. Now, mom produces a lot of that during labor, but that early, we can't mature the lungs fast enough. But on a fully mature baby that's 38 to 40 weeks, mom gives plenty to finish those lungs off during labor. Emphysema, it is a problem exhaling because of air trapping. You have fewer but larger alveoli, so you inhale fine, but air gets trapped in the alveoli and you have difficulty exhaling. This is a restrictive disorder. Nitrogen narcosis, I think this is what Jacques Cousteau identified as rapture of the deep. I think another name was the bends. You ascend too fast, nitrogen bubbles can form in your bloodstream and cause some serious pain, in some cases death. Hyperbaric chamber treatments is how they actually get you out of that. Oxygen toxicity, they tell you in the book if you get above, I think, 2.5 atmospheres of pure oxygen in the system, it'll saturate in the plasma at a higher concentrated level and actually can cause coma and death. And that's an oxygen toxicity. That's why most divers use a mixed gas and not a pure oxygen. they can dive shallow and use pure oxygen, but deep divers sure won't. Decompression sickness, this is ascending too fast, and bubbles of nitrogen form in the blood. Back to the nitrogen narcosis, very similar to this, but I think they say in there it resembles alcohol intoxication a lot. Peripheral chemoreceptors. They're located in the aortic and carotid bodies, and they detect hydrogen levels. Aortic and carotid bodies, and they detect hydrogen levels. Carbon monoxide. Red blood cells, or let's say hemoglobin, has a greater affinity for carbon monoxide than it does oxygen. So carbon monoxide is lethal. It'll bind to our hemoglobin, oxygen can't, so it literally suffocates us. Your red blood cells can only hold so many molecules of oxygen. It has so many seats on it. When those seats are occupied by carbon monoxide, oxygen can't get on. When they use a saturation example in there about if a bus will hold 50 people and there's already 50 people on there, you can't get on. Let's see, DPG, oxygen affinity, I think we covered that right up here. 2,3-DPG, it's increased due to deoxyhemoglobin, and it will allow more oxygen available. Release it. It's increased due to deoxyhemoglobin. I think they tell you in the book oxygen has, oxygen affinity has decreased. In other words, the attractiveness to oxygen to red blood cells has decreased, so it's unloaded quicker. Blood cell synthesis. This is dealing with high altitude, which they talk about in one of those chapters. Due to lack of air pressure, we have lack of saturation of oxygen that will stimulate more red blood cells to be produced. So people up north have thicker blood. People down south have thinner blood. Glomerular filtration, it's 180 liters a day. 45 gallons, I think is what they say. 180 liters a day is probably what's on the test. Like I said a while ago, they see your kidney sees your 5.5 liters every 40 minutes. Renal autoregulation and renal transport minimum. It's probably in reference to more maximum than anything. Renal autoregulation is the ability of the kidney to maintain constant glomerular filtrate rate despite fluctuating blood pressure. Glomerular filtrate rate is 180 liters a day. It maintains that no matter what. It can. It'll constrict or dilate or whatever it needs to do, but it maintains that rate really close to that all the time. That's renal autoregulation. Now, the transport minimum, they talk about transport maximum more than anything. Anything in excess the kidney will get rid of. One thing if you seldom should see in there, obviously, is glucose. So our transport maximum glucose is so high that it's not filtered out. But anything in excess is filtered out. And granted, if you ate 4 boxes of Twinkies and went to the doctor and did a blood test real fast, you'd probably find glucose in your blood.
So the transport
Or
minimum
urine, excuse me,
is anything in excess, what?
will be filtered out. Proximal convoluted tubule, loop of Henle. Well, the proximal tubules where most reabsorption occurs immediately. That's 60 to 65% we had up here a while ago. Most reabsorption occurs there. The loop of Henle, we said really specialized in water reabsorption overall. It's also called the countercurrent multiplier. And they talk about that in the text as well. I'm sure I mentioned it in the lectures. We know the descending limb does water and the ascending limb does salt. Aldosterone secretion. I will say in my regular classes, I make them do an essay question on test 4. I didn't make y'all do that. The essay question is basically tell me what the renin angiotensin aldosterone system does. And it's pretty lengthy, but it's pretty serious what it does. Aldosterone is triggered by the kidney due to low blood pressure and low blood volume. Now, the kidney sees low pressure and low volume. In fact, the part of the kidney is called the juxtaglomerular apparatus. It's a mouthful. It's just a little set of capillaries in there that sees we have low volume and low pressure. And when it sees this, it sends off renin, R-E-N-I-N, out to the bloodstream, which converts angiotensinogen to angiotensin 1. You may want to go back and review this on the... Angiotensin 1 circulates to the lungs. In the lungs, it's converted to angiotensin 2 by another enzyme called ACE. You ever heard of ACE inhibitors for hypertension?
Mm-hmm.
Calcium channel blockers?
Okay, that's what's
Okay. So anyway, that's where some of these things come from. Now they have angiotensin 2 inhibitors, which angiotensin 2 now that's formed does two things. Immediately it causes vasoconstriction of vessels to increase pressure. Secondarily, it goes to the adrenal cortex to produce aldosterone, which will reabsorb sodium. What follows salt? Water. So that'll build volume and pressure over time. So it gives us a quick fix and a long-term fix at the same time. And that's what they have to do on the essay question in regular classes. Y'all could handle that on this one, couldn't you?
Sure.
Make sure I got it. The aldosterone also is produced in one other case, when we have high potassium. Too much potassium will kill you. Aldosterone is our mechanism to get rid of it. If you go apes and eat a lot of bananas, aldosterone will save your life. So when it increases the reabsorption of sodium, it always excretes more potassium. But not enough potassium will kill you too, so it doesn't hurt you to eat a banana every now and then. Capillaries in the lungs, this is where ACE is at, the enzyme that does the conversion. This is where ACE, and that really stands for a converting enzyme, so that was a real brain surgeon to come up with that. And they have another theory about that in there somewhere. Aldosterone secretion in adrenal cortex, I just went over that in that whole theory that I just gave you. Alkalosis. Both, they talk about in the chapter respiratory alkalosis, respiratory acidosis, metabolic alkalosis, and metabolic acidosis. They talk about all of them. In theory, respiratory actions can correct the problems. Metabolic is directly dealt with non-volatile acids. And basically, in metabolic acidosis and alkalosis, we have a disruption in bicarbonate levels. Okay? In respiratory acidosis and alkalosis, we have a disruption in carbon dioxide levels. which those are somewhat directly correlated. So if we have, respiratory is much easier. Let's say we're exercising and we have an increase of CO2 in the system. How would you correct an increase of CO2 in the system? You would breathe faster, you would hyperventilate. If you have low CO2 in the system, how would you correct that? Hypoventilate. So, whether it's respiratory or metabolic, if it's acidosis, you need to hyperventilate to correct it. If it's alkalosis, you need to hypoventilate to correct it. I give one other example in there in the metabolic end of it. Would you have metabolic acidosis or alkalosis if you were seriously ill, vomiting your guts up? That's what you're getting rid of, what's left. If you're vomiting, you would have alkalosis because the alkaline secretion's in your small intestine and below, and that's what's left. If you have diarrhea, you would create acidosis because you lost all the alkaline secretions through the diarrhea, and what's left in the stomach? Acids. If you have the 2-bucket flu, you're neutralized and you're fine, right? You're just totally dehydrated and on your deathbed, that's all. Some of y'all grin because you've had the 2-bucket flu before, right? It's ugly, isn't it? All right, glomerulonephritis, these are both right at the end of that kidney chapter, and they talk about these. I wouldn't worry about that second term, that pyelonephritis. Glomerulonephritis, they think it can be an autoimmune disease, causing inflammation of the nephrons. It can actually be caused in some cases by antibodies produced by the strep bacteria, just like, what is it in the heart where it attacks the valve? Rheumatic fever, just like rheumatic fever. So you might want to look that up, do a little extra studying on that one. Stomach churning, you throw all, we're in digestive chapter now, you throw all the food down in the stomach and it churns it all up, throws in about 2 liters of acid, and we've got stomach chyme. That's what we have. CHYME. If you vomited before, you've seen a pile of stomach chyme. It's ugly. 2-bucket flu. That's what you spit up.
And at the very end, like it's.
No, that's dry heaves and bile and phlegm. Now, the chyme already came. You have nothing else to spit up when you're coughing up phlegm and bile.
That's the worst part of it.
That's your liver tickling your tonsils there.
Ew.
Yeah, the dry heaves are way worse. Helicobacter pylori. This is a bacteria that can cause peptic ulcers. We all have it. It just affects some people worse than others. We used to treat it with surgery. Now we treat it with an antibiotic and an antacid. We learned that from vets who treated the same thing in pigs with Pepto-Bismol and a $5 antibiotic. If we did a $3,000 surgery on a pig, we'd have said, forget that, shoot the pig and eat it. But this is actually normal flora of the stomach. It just gets in the wrong place at the wrong time when everything else is weak and it causes problems. They're actually connecting this to obesity now. They're seeing, we take so many antibiotics these days, we have less of this in our system because it kills good and bad. And the people with less of this in their system tend to be more obese than people who have normal amounts of Helicobacter pylori in their system. Well, that brings us to stress. Stress in the GI tract. Will stress increase or decrease GI tract motility? If you're highly stressed, do you feel like stopping off and eating at McDonald's?
No.
Some people eat their way through an oblivion of stress, but most people wouldn't. Your digestive system really shouldn't be focusing on eating if you're under heavy stress. And they're thinking of it in the text as a fight or flight, a life or death situation. You're certainly not going to you've seen the test, you're not gonna be chased by a bear through the forest and think, if I can get away from this bear, you're thinking the whole time, I'm gonna swing through the drive-thru at McDonald's.
Yeah, that's right.
Yeah. Functions of the large intestine, mainly water reabsorption.
So you're saying on that one, it decreases it?
It's gonna decrease it. Yeah. Stress will decrease GI tract function. According to our last test, it would decrease not only digestion, but excretion and reproduction, right? You're not gonna think about any of those if we're trying to survive. So water reabsorption on function of large intestine. Kupffer cells, that's probably where the test question's gonna be. Kupffer cells are your natural immune response cells of the liver. Langerhans cells are in reference to some cells in the pancreas. You can look those up. Remember the islets of Langerhans, you have alpha and beta, so you get insulin, glucagon. You want to look those up too. Hepatic portal system. This is a very unique system in that this is the only system in the body that has a vein coming into it and a vein going out of it. All other organs have arteries coming into them and veins going out, so this one's kind of unique. Zymogens. Zymogens are inactive forms of pancreatic enzymes. Inactive. When pancreas produces them, and they're traveling down the pancreatic duct, we don't want them activated, they'll eat the duct before it gets there. They make it to the brush border enzymes activate them, and they go after the food that's there. Preeclampsia, there's one of those special boxes in this chapter about preeclampsia. It's simply elevated blood pressure, extra swelling.
It's actually in chapter 14. It's not
That is back in 14, isn't it?
14.
I don't know why I had thrown in here, but I guess if it's 14, you should already learn that. A lot of times leads to emergency C-sections to save both. They'll even find extra protein in the urine as well. Pons and medulla, that's inspiratory and expiratory centers. This is, I'm not sure what chapter that's mentioned in, besides 8 and 9, but it is in one of these chapters again. That'll be the respiratory chapter, 16. Yeah, the medulla has the I centers and E centers. I for inspiration, E for expiration. Another brain surgeon put that together. And of course the pons has the amniotic and pneumotaxic centers, which the amniotic center encourages inspiration. The pneumotaxic center stops inspiration. If we stop inspiring, what are we going to do? We're going to be expiring, not as in death, but breathing out. If we stop breathing in, I guess we could die, couldn't we? There's a chart in that same chapter that goes over several terms. Dyspnea, eunia, apnea is another one you really should look at in that chart, where you stop breathing at night, or anytime, I guess, but when you're sleeping, you stop breathing. Look at that chart and those definitions. Eunia sounds horrible, but it's normal. It's normal breathing. And dyspnea is shortness of breath. Medullary rhythmicity is influenced by the pons. Just keep in mind the pons deals with the rhythm. The medulla tells you if you're going to breathe or not. The pons deals with the rhythm. Surfactant is a lipoprotein produced by type 2 alveolar cells. We already covered renin back in the renin-angiotensin-aldosterone system.
Lipoprotein what?
That's secreted by type 2 alveoli cells. Type 1 alveoli cells make up the surface area of all the alveoli about 90% of the lungs are made of type 1 alveoli cells. Vital capacity, residual volume, there's another chart in there that tells you what tidal volume, vital capacity, residual volume, inspiratory reserve volume, expiratory reserve volume. Just know those definitions, they're not difficult. Bicarbonate and phosphates are buffers. They're simply that, they're buffers. Red blood cell production, what organ would control that? Would determine if we need more red blood cells or not? Kidney. Liver's gonna kill them off when we're done with them. And the hormone's erythropoietin, but it is produced by the kidney. Acidosis, we've already covered that, I think. Anemia is when you're lacking oxygen on the hemoglobin. Now, we may be lacking hemoglobin, the reason we're lacking oxygen. There's different kinds of it, but we're lacking oxygen, and it may be due to lacking hemoglobin. Carbonic acid, I'm not sure what to say about that. That's what's produced when we add carbon dioxide to water. So that the increased carbon dioxide would increase carbonic acid, so it could cause acidosis. We fix it by hyperventilating. Does that make sense? Increased CO2 increases carbonic acid. How do we get rid of it? Get rid of the CO2. Glomerular filtrate rate in males, 125 milliliters per minute. We said a while ago 180 liters a day, right? Well, they've got it down to the minute now. And that's 115 in females. I don't think I asked that, but it's 115 in females and 125 in males. What is the countercurrent multiplier? The loop of Henle. Renal plasma clearance. The section in the text that talked about renal plasma clearance actually talked about a substance found in garlic, onions, artichokes, and dahlias. Dahlia is actually a flower. I guess it's an edible flower, but the substance found in those is called inulin. And inulin, I hope I'm pronouncing that right. Inulin is almost identical to sugar, to glucose, but the body doesn't recognize it. So the amount you consume is the exact amount it excretes, gets rid of it. You ever heard of garlic being good for blood pressure? That's the reason, because since it's a sugar, water will follow it out of the system, so it lowers volume and lowers pressure. I guess garlic can help you in two ways. You have bad breath, you don't have to deal with people, they won't hang around you. So it lowers blood pressure in two ways. I believe it's inulin. I believe that's right. Where are we at now?
Collecting ducts.
Collecting ducts, the only thing they can become permeable to is water, and they can be influenced by ADH. ADH, anti-diuretic hormone. Urinary system function, well, we just went over all that. I say we did. We certainly did in zoology right before y'all came in. The nephron's a functional unit of the kidney, and each one of our kidneys have about 1 million of them. You need 25% of those to work. You'd want more, but you need 25%. Afferent arteriole and efferent arteriole. Afferent arteriole is the one coming into the glomerulus, and the efferent's going out of the glomerulus. If the afferent arteriole was obstructed, we would have lack of flow into the nephron, wouldn't we, if it's the one coming in? So I would just kind of get a visual of blood flow coming into that, and you have that flow chart in your notes. It's toward the end of the package of notes, and it looks something like this right here. It'll have, get up there where the camera can see it. I hope you can read that. At the top, we have blood flow into kidney, entering a nephron, and the bottom is the parts of the nephron that it corresponds with. And your correspondence is glomerulus, Bowman's capsule, efferent arteriole proximal tubule, peritubular capillaries surrounds the loop of Henle, and distal tubule and renal vein. There's your correspondence in that. Renal stones, gosh, there's so many theories on what. Calcium is the biggest buildup of those, most common cause. Your body doesn't utilize calcium very well, so it creates these little stones that look like, oh my gosh, a bad piece of sandpaper crawling around in there. I've looked at them with a microscope. No wonder they're painful. They just rip the inside of the urethra apart. It's unreal. Functions of the liver: secrete bile, carbohydrate synthesis, protein metabolism. There's tons of things that the liver does. Not only break down red blood cells, but they produce a lot of proteins as well. Emulsification of fats, lipid metabolism. This is actually done by bile in the small intestine from the liver. So another kind of falls under liver again. Where's bile stored? Gallbladder. Trypsin, lipase, amylase. A lot of these are made in the duodenum, which is the brush border of the small intestine. Duodenum's the first portion of the small intestine, and that's where most of your brush border is.
That's where it absorbs everything, right?
Yep, that's where absorption can occur throughout it, but the starting of the digestion of the molecules really starts at the beginning, and this is where the pancreatic duct's going to come in and convert those zymogens we mentioned will go into active processes, and the brush border's producing these. Trypsin converts, enterokinase converts trypsinogen to trypsin, and enterokinase is produced by the brush border. Trypsinogen is produced by the pancreas. It gets there as inactive. Enterokinase converts it to trypsin, and now it starts breaking down proteins. Otherwise, it'd eat up the pancreatic duct. That wouldn't do us a lot of good. pH of pepsin, 2 is where we're at in the stomach, and pepsin is got to have a 2 pH to work, and it's going to digest proteins. If we generalize really what's happening here, and I seem like I asked a question about this somewhere, protein digestion begins in the stomach, period. And there's only 3 things absorbed in the stomach: aspirin, alcohol, and botulism. So where's all your absorption going to occur? Small intestine. Yeah, except some water. Whatever's left over, its large intestine grabs it to solidify the waste. Blood bilirubin. Bilirubin, that'd be a great name for a boy. What do you think, Courtney? You have a boy named him Bilirubin just for this class? I tried. Jaundice, increased red blood cells in the system that are not getting broken down fast enough. That's what causes jaundice. The book goes through quite a little process in there to make this soluble in blood. It goes from bilirubin to conjugated bilirubin. We end up peeing a lot of it out in an amber color, a pee, and it also, the rest of it goes in the feces and makes it a brown color. So that's, and some of it stays in the system to do what it's got to do, but that's where we're at on the study guide.
Well, you wanting to know
Bilirubin?
Yes.
What you gonna name your firstborn? Oh, that's what I said first, but, increased bilirubin in the system causes jaundice. And that's due to not breaking down red blood cells as fast as they're dying, not getting rid of them fast enough. Now, there's a section in the text, I would recommend to read through it. It's a little bit confusing, but if you read it 2 or 3 times, you think, well, that's pretty cool, actually, the way it goes through all this, but. Will there be a cajillion questions over bilirubin? No.